inequities. The New York Times series should be a must for every high school in America. In this morning's program, our eminent speakers have a big task. They will unravel the root forces that are culpable for where we are, encapsulate the case for reparations, and remark on the challenges public health faces as a result. I'm also hoping, as I'm sure you all are as well, that they might help us chart the way forward. You can read more about each of their impressive biographies in your programs, but I will briefly introduce each of them all at once, and then they'll successively come up and give brief remarks, and then they'll join each other on the stage. My friend and former colleague, Dr. Mary Bassett, is the current director of the François-Xavier Bagnoud Center for Health and Human Rights at Harvard University. Before that, as you all know, she served as one of New York City's bravest and most beloved New York City health commissioners. Another dear friend, Katherine Franke, is the Sulzbacher Professor of Law, Gender, and Sexuality Studies at Columbia University, and writes extensively, passionately, and cogently about social and racial justice in the United States and elsewhere. And last but not least, and in fact she will go first in our program, Linda Villarosa has been a figure at the New York Times for as long as I can remember. That doesn't mean you're old, it just means that you've been in my mind for a very long time. Not at all. She deftly uses her craft to examine some of the most challenging health and social issues of our time. In addition to being an editor on the 1619 Project, she is professor of media and communication arts at City College. Most importantly, she's also Callie's mom. Callie is my ace and wonderful assistant who has helped ensure that every single detail of this event has been taken care of, so thank you, Callie. Our program will begin with presentations from each of our speakers, followed by a discussion moderated by Katherine Franke, who's playing a dual role here today. Thank you very much. We will then open the floor for questions from all of you. So without further ado, let me introduce our first speaker, Linda Villarosa.
Good morning. I'm very happy to be here. Thank you, Sandy. I'm really thrilled to share the morning with Katherine and Mary, who I deeply admire and I've learned from, and my daughter, who I'm really proud of, works here, and my mother is here this morning, so we have a lot of Villarosas in the house. I'd like to talk about the 1619, how I came to the 1619 project, sort of tell you a little bit of behind the scenes, how it came about, and a little bit about how it's been received. I'm a contributing writer at the New York Times Magazine, which basically means I don't go in every day. Yay, because it's really stressful at the New York Times. But I got a call to go in the spring, and they said, we've got this really interesting project we would like you to contribute to. And because I cover public health, I thought it was sort of a health thing. But then it turned out Nicole Hannah-Jones was in the meeting, and she is our MacArthur Genius Award winner, and she covers race and education and inequality. And she started talking about this project that would look at 1619 as a marker because of the 400th anniversary in August, and look at 250 years of slavery, and we were calling it slavery then, we call it enslavement now, because we had to change the language in working in this project. So look at the contributions of African Americans as well as the consequences of enslavement. So we all had to go back and pitch stories, and think of stories and then pitch them. So my first round of stories was all about the terrible things that happened. And it was really easy to find. So the ways that enslaved people were experimented on, or the ways, the sort of terribleness of enslavement. And then we all got sent back to say, we don't just want that. We want you to look at the consequence of slavery that lasts today. And so that was a different charge and much more narrow. So what I did was chose two two consequences of slavery that still exist today. The first is the idea that Black people have lower lung capacity. So there's a lot of information on this in history books, but I was surprised that it began with Thomas Jefferson. And it was almost a throwaway in Notes on the State of Virginia, which is not about that. But he takes a deep dive into physiological differences. And it's strange, some of the things he was saying. And then almost as he just mentioned, Black people have lower lung capacity, have inferior lungs. So that seemed to have been picked up by doctors, mainly Southern doctors at the time, who were looking for ways to justify the cruelty and, enslavement. And so the idea was not only that African Americans had inferior lungs, but also that hard work in the fields made your lungs stronger. And the person who was the most key figure in this was Samuel Cartwright. So he was a physician, and that's what was sort of shocking about a lot of the myths that I was looking at, were that physicians were the ones pushing them forward. So Samuel Cartwright also, he latched onto this whole lung thing, lung inferiority, but he also created this disease called drapetomania. So drapetomania was a mental illness that enslaved people got, and it caused them to run away. So, and it's sort of like, I was at first laughing about it, and then I thought, wow, this guy is presenting this at a medical conference. He's at Tulane, what is now Tulane University, presenting this. It's in a scholarly journal. And so it meant that other doctors picked up on it, scientists picked up on it, and then also people picked up on it. So even after enslavement ended, he was testing his theories on a machine called a spirometer. So the spirometer tests lung function. But here's where it goes to the present. So the modern day spirometer has a race correction that assumes that Black people have a 10 to 15% lung inferiority, even now. So that still exists in the current spirometer. So you input, if a Black patient is sitting in front of you, physicians input that, and it automatically calibrates for the 10 to 15% lung inferiority. So why is this, from this crackpot, Samuel Cartwright, this lung inferiority still exists in modern day? And what are the consequences of it? Because lung function, I had a lung function test when I had bronchitis, and I wonder if my doctor put my race in, which meant that there was an assumption that I had a 10 to 15% lung inferiority, though I grew up in the state of Colorado in the Mile High City, so I should be, I'm the Serena Williams of lung function. The second myth that I looked at was pain tolerance. So clearly there was a reason for saying that Black people had super high pain tolerance, almost a superpower against pain, because that meant our people could be whipped and beaten and worked from sunup to sundown. But the idea that this still exists in modern medicine is the weird part. So in 2016, there was a study, and it was on medical students and residents. And so they were asked to rate patients' pain. And so in these, surveys, they consistently rated Black people having less sensitivity to pain. And it was kind of significant. And I didn't just look up that study, because when I cite these studies and this information, I get a lot of pushback. So I got a second one. And the second one was kind of more brutal, because it asked, if you have two patients, one Black and one white, and the patient's hand is slammed in a car door, or broken leg, a bone snapped and broke, what is the level of pain? And doctors and, doctors to be, medical students and residents, consistently rated Black people having less sensitivity to your hand getting slammed in a car door or a broken bone. And this is modern day. So I think for me, it was shocking, but it was also easy to find. After my essay appeared, I was surprised by the amount of pushback I got, mainly from physicians who didn't believe the research. And luckily, I rarely read comments because it's too upsetting. I only read the good ones. And, but I did look at these, and I was surprised by, people saying, well, it wasn't like this. I didn't learn about this barometer in medical school and this lung function thing. It's like, well, okay, good for you, but it does still exist. And so I think we have a lot of work to do in this area, especially if myths are believed by not just the current physicians, but the physicians to be. So I'm going to stop there, and I'm excited for the rest of this conversation. Thank you.
Well, thank you, Linda, and good morning, everyone. It's really such a pleasure to be here. And back in New York City, a lot of my colleagues are in the audience, so thank you for coming. As you all know, when I became health commissioner, I decided that I would make racial equity and social justice sort of the hallmark of my tenure. And I had the opportunity to speak to a journalist who I'm afraid I don't remember his name. And he said, well, you're health commissioner now, what's your thing? The two commissioners back, it was tobacco. The one before you, it was sugary beverages. And I said, I think I'm gonna be focusing on racial equity and social justice. And they said, well, how are you going to measure that? And so that, I replied to that, the words that somebody famous said, that not everything that matters can be measured, and not everything that's measured matters. And so I want to say, before I launch into my remarks, because I have some slides, that I'm really so pleased that Vital Talks and Vital Strategies are tackling this issue. I mean, the organization is really known for its strict approach to a lives saved mode. This is about saving lives, but not in the same readily measurable fashion. And so we, somewhere down here, I have my clicker. So I've really been thinking a lot about histories and the ways in which history affects how we think about race. And how do I advance this? Somebody's going to help me. And so I thought that I would start out by pointing out that these histories are also personal. And I don't think that these are my slides, but yeah, there they are. And the next one. And which one do I push? The middle one?
To the right. Yep.
This one. All right, so I thought you won't be able to make this out, but this is for a page from the Henry County Census in 1860. And it's a whole list of names. And on this list of names, there, maybe you can see it in the front row, is Mary Travis. That is my great-great-grandmother. She appears on the 1860 census, which means that she was free. She's listed as being mixed race. And she was named by her, my grandmother was named Mary Travis. Her father named him after his mother, and my father named me after his mother. So I'm the third Mary Travis, is Mary Travis Bassett. And so this, she was mixed race and free. 1860 was the last census before the end of the Civil War. It was only after the Civil War that people who had been enslaved, and that word really does make a difference. It reminds us that this was an action, not a state. And she was, 1870 was the first post-Civil War census in which people who had been enslaved were named by name on the census rolls. Before that, no names appeared. What I want to talk about, though, is the sort of silence that's existed around public health and race. There are, I don't know, I want to advance this, but I'm not succeeding. Where's my assistant? Do I need to aim it somewhere? Oh, good, they're all around the room. So you can, maybe some of you could see Mary Travis there on the census rolls. And anyway, this is just to remind us of the transatlantic slave trade, in which 12.5 million Africans were crossed the Atlantic. And you can see it was a very skinny arrow to North America. The bulk of people were transported to South America and the Caribbean. And the fact that people of African descent and the one-drop rule kept people under the definition of being black explains the fact that the U.S. has such a large population that is defined as of African descent. Can I have the next one? What am I doing wrong? This? Yeah. And this is just an homage to the 1619 magazine that you heard Linda talk about. It's a collector's item. If you haven't read it, you should find a way to get a hold of it. And I think one of the points made in that article were the words that were echoed by one of the first women to run for president, not Hillary Clinton, Shirley Chisholm, who noted how race has really continued to be invisible in the United States. And I thought that I would reflect on how it's affected public health. And this is just some photographs of wonderful books about the history of public health in the United States. Probably The History of Public Health by George Rosen, now in paperback in 2 volumes, is the best book I've ever read about public health. And when I found it, it was initially published in the 1950s, and it was sort of resurrected and republished in the 1990s. It really gave me a picture of what public health is all about. It begins with the Greeks, and it carries on through what many of us view as the high point of public health in the 19th century, when public health really was about truly structural issues: water, sanitation, building codes. And as Evelyn Hammonds, a historian of science at Harvard University, points out, people of African descent are hardly mentioned in this book. The only thing that's noted is higher mortality rates. And there's never been a time when people of African descent in this country have not been sicker and died younger than people who are classified as white. But they receive no mention. It was immigrant history, the teeming tenements, the horrors of urbanization that really drove what we think of as modern public health. But public health did not turn its attention to the state of enslaved and then newly freed people of African descent. And this continues into the books that were written about New York City's health department, which John Duffy, people at the health department probably know this book, maybe nobody else does. It's in 2 volumes. It goes up into the mid-1960s. He also focuses mainly on the European immigrant population and doesn't talk about the population that fled the South and came to New York City, and a fact that continues into his later book on the sanitarians. So this has been a long-standing blind spot in public health, and one that I think we must relate to the histories that you're going to hear about from Katherine, and you've just heard about from Linda. Next slide. It was not like that everybody saw this as a blind spot. The really seminal intellectual of any race, I would say, of the 20th century, W.E.B. Du Bois, wrote in the early 1900s a book called The Philadelphia Negro, in which he makes a strong case that it's nothing intrinsic about being of African descent that explained the terrible health of the black community of Philadelphia. He ascribes it entirely to the context in which people lived. He points out that there is a class gradient in health related to the class gradient among the black populations of Philadelphia. And he makes a strong case against the biological definition of race, which continues to threaten our ability to pursue racial equity with these kind of ideas that Linda wrote about her piece in the 1619 magazine. I think that may be my last slide here, which is how I came at the health department to think about how we should tackle the idea and analyze when we're going off the tracks in thinking about what explains racial differences in health. The two dominant theories are of both lay responsibility in the hands of individual people. One says that black people have different genetic and therefore different biological makeup than white people, one that accepts the notion of a biological difference as a basis of race. The other makes the argument that we have a damaged culture, that something about us explains poor decision-making and unhealthy choices. And, next slide, thank you. If we should just always ask ourselves, what is the person who's explaining these differences ascribing them to? And if the problem is the people, you should interrogate it as a racist idea. And last, because Katherine Franke is here, and I just finished reading her book on my ride down from Boston, and then my ride down from what people call upstate Manhattan this morning, something that has come to interest me now that I'm in academia is the whole question of whether public health can contribute to the conversation about reparations. Thank you. And thank you to whoever did my slides.
Good morning, everyone. Thank you, Sandy, for inviting us to come talk today about the relationship of our history of white supremacy in this country and racial disparities in health today. We're having a little technical issue, but let me start off with two questions that I'd love us to chew on just now and then also during our conversation between the three of us and then your questions later. The first is, to what degree does emancipation, the ending of the institution of slavery, have anything to do with freedom? That is, are people who were emancipated actually free? Hold on one sec, we'll get to it. Yeah. Secondly, what is the relationship between freedom and health? Is the fact that certain particular communities of color in our society experience significantly diminished health outcomes, health indicators, actually a sign that they are less free? So I think we can connect the dots about freedom and about public health in a way that will be quite productive for us today. So I've written this book, and there are a few of them out in the front there that I'm happy for you all to just rush out and grab, called Redeeming the Promise of Abolition. And the book takes up those questions. And I was wishing we had the PowerPoint working because I always, when I'm talking about reparations and when I'm talking about the history of slavery, I like to bring enslaved people into the room. If we're going to speak about them and in their name, it's important to have them with us. So they'll be with us in a second. They're on their way, I'm sure. Orlando Patterson, a sociologist of race and of the history of the United States, noted in a fundamentally important book in 1926 that slavery is a form of social death. Actually using terms one might borrow from public health, that slavery is a form of social death. If upon the emancipation of enslaved people, that social death ended, what kind of social life was inaugurated through their freedom? great. That's later on. Here, so here they are. Here they are. This is a group of people from a plantation in the Sea Islands of South Carolina. In 1861, when this photograph was taken, there were 10 to 15,000 enslaved black people in the plantations in the Sea Islands. And if you've ever been to the Sea Islands, it is a breathtakingly beautiful place. And a place with a horrendous history, a history of slavery. And so here we have a group of people. Imagine the kind of health outcomes they experienced as enslaved people living in conditions as they lived while enslaved. Now, this is 1861 in November, early November. This is a day later. Similar group of people. In terms of their sense of freedom, their experience of freedom, the only difference between this group and this group, come on, is the presence of a white man. You can see him standing in a uniform in the front. The federal military arrived in the Sea Islands in November of 1861, and by their very presence, freed the 10 to 15,000 enslaved people who were there, just by their presence, right? No Emancipation Proclamation, no amendment to the U.S. Constitution, but just the presence of the U.S. military. This was rolling out throughout the South as the Northern military worked their campaigns through the South, emancipating what we would now call groups of refugees from slavery. We didn't use that term to describe these people at that point. We called them contrabands. Contraband is a sort of old-fashioned term of items, of property that you seize from the enemy, right? Material, like, so it could be their guns, their ammunition, their tanks today, things like that. These people were described as contrabands. What happened, though, in the Sea Islands was phenomenal when we think about how we might have inherited a more just society today than the one we live in. The military officials who were in charge of tending to the needs of the freed people in the Sea Islands sat down with them and asked them what they wanted. And they listened. And these folks knew exactly what they wanted. They wanted land, and they wanted the white people to leave. They said, we can't build new lives with you all here. And so Rufus Saxton, who was tasked with this project in the Sea Islands, specifically understood that reparations were owed to formerly enslaved people, to the newly freed people of the Sea Islands and elsewhere. That merely abolishing the institution of slavery was not enough, both as a backward-looking matter, because we needed to recognize through some kind of repair the horror of enslavement. That horror was certainly the social death that Patterson describes, but physical death as well. Torture, family separation, rape, using women as baby machines in order to create more slaves. Right? All of that, certainly also the theft of their labor, but not only that. So reparations were owed in a backward-looking sense as repair for the horror of enslavement, but also as a forward-looking matter, that you could never be a free people without any material resources. So to liberate or emancipate or free a group of people into abject poverty was no form of freedom at all. And they understood this very clearly. And as you see what Saxton says, the formerly enslaved people of the Sea Islands had a mortgage, an equitable mortgage, in the sense of that land was owed to them as a form of repair. And they got it. This is the thing that's amazing. And here's a deed. This is an enlargement of this earlier one. I've spent years in archives looking at these documents. These are the deeds that the federal government gave to the formerly enslaved people of the Sea Islands for the property on which they had been enslaved, and their parents had been enslaved, and their grandparents had been enslaved. And they could not write their names because, of course, it was a crime in South Carolina to teach an enslaved person how to read or write, but they could write their names with an X. And you see the X's here. And also, when I'm in the archives looking at these documents, I also see smudges of ink from their nervous hand making an X as they put the quill into the ink and maybe spill it and it ends up on their thumb or their palm. These are the first acts of freedom that the formerly enslaved people of the Sea Islands engaged in. A magnificent and probably disorienting moment for them, but it was also the beginning of what would be a life of their community together, apart from white people, where they could build free lives. What they also did is they went out into the areas in which they had been enslaved, those plantations, and they drew maps for collective places where they would live, not in nuclear families like we understand property ownership today, but collectively in complex kinship groups. So at the very bottom, you can't see it, but probably very well, it says the burying ground. And then you've got a pasture field on the left up to the top to the cutoff creek, right? They were not plotting out rectangular grids of property like property is often plotted out. They were plotting it with their hearts and lives and saying, this is how we know this land and treasure it, by the markers in the land that were meaningful to us, not some random squares or rectangles. You also see here that it was women, black women, who were making claims to land. And in 1863, 1864, and this is December 31st, 1863, white women could not own land. We had laws in the United States that deprived white women of the right to own property. But black women were getting land through this reparations project, which is really quite astonishing and quite wonderful. Right? So these deeds were given to them for the land. They began to plant corn and wheat, not cotton. Never wanted to plant cotton again. Right? They wanted crops that they could eat. Right? And what happens? The war ends, as you might remember from middle school. The North wins. The institution of slavery is formally abolished through the Emancipation Proclamation and then later the 13th Amendment. But President Lincoln is assassinated. And the new president, Johnson, the first thing he does in office is grant amnesty to the former Confederate and plantation owners and restore their land. All of this land is violently removed from the enslaved people, formerly enslaved people who owned it, and the white people who had owned them got the land back. And all of these people, and I want to go back to them because I want them to remain with us, were forced to enter into year-long labor contracts with the people who had owned them before. They were forced to work for a wage for which they were very infrequently paid, but in theory, free labor under these contracts. And a series of policies went into place to criminalize so much of black life so that they could populate the prisons with black men who would then be leased out through something called the convict leasing system to do the agricultural work that enslaved people had done before, because the freed people were not as willing to work in the ways that they had been forced to work when they were enslaved. So the white landowners and white politicians created a new form of servitude through the convict leasing system, which was more deadly for black men than was labor under conditions of enslavement. More black men died in the late 1860s and 70s through the convict leasing system than they did while they were working the exact same fields while enslaved. Why? If you think about it, if you own an asset, you have an investment in its long-term productivity. If you rent it or lease it, you're happy to use it up for the period of the lease. So as a matter of public health, a matter of social life as opposed to social death, being freed was actually more perilous than being enslaved for many of the people who had been freed in the Sea Islands. And for this reason, I make a big distinction in the book between being freed and being free. And we continue to live with that legacy today, that we haven't fully granted freedom to black people, we have freed them. And I think that the health disparities that Dr. Bassett and that Linda Villarosa writes about in her work as well, race-based disparities in health are evidence of the fact that Black people are still not fully free in this country. Thank you. So I went, thank you, our mics are on. So we're gonna pivot into a conversation between the three of us and then take your questions. This is such a rich conversation, such an enormously rich conversation. I want to ask both of you, to what degree in the work that you've done, the context you've studied, would you connect the dots from enslavement to being freed, but not fully free, to the disparities that we see today? What is the evidence of that, and what are the drivers of it? Dr. Bassett, you want to
Okay, yeah, no, well, I really first want to thank you for a really eloquent exposition of your book, which everybody should read. And these are a continuum. The goal of maintaining Blacks in an economically productive but socially unfree state never went away after the end of formal enslavement. It was followed by the Black Codes, then by Jim Crow, and then by mass incarceration, which, as you know, the U.S. incarcerates more people than any other country and more people from a single minority group than any other country. And I consider these a direct continuum, and I agree with you that the racial disparities that we see in health and in life expectancy are a measure of the extent to which people of African descent have never been granted full citizenship in the United States. The fact that I often tell people is looking at the survival to the age of 65, which until pretty recently was considered a cut point for premature mortality. Mm-hmm. Whites achieved 65 years of life expectancy in the 1940s. Black women achieved this in the 1950s. And then I often turn to the audience and say, do you want to guess when it was for Black men? Anybody want to guess?
It's not.
Yeah.
Well, you are an educated audience, but the answer is that not until 1995. So that was a full 2 generations after the white population. And that reflects the lack of equality. It doesn't reflect some personal failure. It reflects a structural problem. So,
right.
We should, if we achieve, we'll know that we've ended racial inequality in the United States when we no longer see racial differences in health statistics and life expectancy.
Yeah. Linda, your work has focused certainly on the issues of lung capacity and capacity for pain that you talked about in the 1619 piece, but also on infant and maternal mortality, which can also be a pretty significant indicator given the racial disparities in this country. Maybe you could connect that back to this history.
When I was working on my story about maternal mortality and infant mortality, I hadn't done the 1619 piece. So I was shocked by what I learned in that story, which kind of started out with a number. So the number was disparities in maternal mortality, and why are we the only developed country or rich country where the numbers of women who die in childbirth are going up? And then why are Black women 3 to 4 times more likely to die related to childbirth and pregnancy? And then why does class not protect us so that a Black woman with a master's degree is more likely to die or almost die than a white woman with an 8th grade education? And so that's what really struck me. And then when I started working on the story, I was only thinking about maternal mortality. And then I thought, wait a minute, infant mortality in Black parents and children there's also a disparity. And it's only one woman's body. And so I started thinking about them together. And by the end, because I realized, wait, it's not about class. This is really horrible. It's changing our own global health status by, why is this rich country having this problem? And by the end, I thought, this is because of what's happening with Black women and babies. And it's left over from, it's old. And part of it is discrimination in our current healthcare system, which I was shocked to see it unfold in front of me. So when I was following the mother in my story, Simone, when she went into labor, how she was treated, with me standing right there and her doula standing right there, was unconscionable. I wouldn't let someone I loved that happen to her. And thank God her doula was there. Her doctor treated her badly. She was in crisis. They weren't really paying that much attention to her and her needs and her feelings. The doctor that delivered her baby was someone we met for the first time when he put his hands inside her. And so it was surprising, and it changed the reporting of that story for me, because I saw this discrimination that was then, I traced back to the years of enslavement in my later pieces. But it kind of has all come together in my head, at least, that this is an old problem. It is about discrimination, and it's also about discrimination in our society.
Yeah. Dr. Bassett, you wrote just a phenomenal piece in The Lancet in 2017, a published piece there, on structural racism and public health. And it's, if you haven't read it, you must. I'm a professor. That's your homework. And in the piece, you make this very important distinction between accounting for race and accounting for racism in public health policy. What is that distinction, and why do you think it's so important?
Well, first, I want to acknowledge that the first author on that piece was Zinzi Bailey, who was one of the junior investigators, so we wanted to promote young people. So it was a collective effort. But I heard Reverend Barber speak recently, and he said something that I think speaks to your question. He said that race is the child of racism and not its father. So let me just say that again. Race is the child of racism and not its father. So racism is not just the distinctions that we may make physically, which are ones that really should have, the Bob Marley sign until the color of a man's, his song that said the color of a man's skin should have no more significance than the color of his eyes. And until then, there'll be war, something like that. We have a Jamaican in the house, so. So racism is a set of social relationships that result from a dynamic of white supremacy and Black inferiority, and that has extended for all people of color in the United States. The ideology of white supremacy has functions throughout our society. And this piece was about structural racism, which is a concept that says it's not only about personal prejudice, it's about the way these power relations are enforced and produced and reproduced across institutions within our culture. Redlining is a really good example of structural racism.
So give us an example of where you would see something different if you looked at a public health set of indicators or area that you're working on, and look only for race as opposed to looking for racism. What would you see differently through the lens of racism than through race?
Well, that's a really interesting. I've never asked myself that question. I think I usually think of it as an explanatory difference. In other words, race represents very often when we look at racial differences, we're interpreting them as biological or social behavioral differences. And instead of seeing them as ones that are based on a social consensus of Black inferiority. So the solution to structural racism is structural changes. You raise some of them in your book. The idea of land ownership, for example. An opportunity at home ownership was
was removed by the government's decisions around access to low-cost mortgages in the 1930s, for example, in the process called redlining. So that's an example of racism. It's not simply a descriptor, it's an action based on the idea of white supremacy and black inferiority. Am I getting at what you're after? I'm not sure.
Well, you're the expert. I'm just asking the questions here. But I do think there's a way when we ask, I mean, that this line in your piece and the whole piece that you and your colleagues wrote got me thinking about this question of how do we measure power, not just identity. And when you're counting people by what race they have and then measuring how many of people of that sort are in this group or being treated in this way, there's both a risk of individualizing it, of just saying, well, because you're black, that's happening to you, and which both of you have written about. But also, you don't have the tools you need to understand power and structure as easily when you're counting race as opposed to looking for racism.
Yes.
Well, I think part of this is in the solutions that we, that we give people who, so if you take heart disease, for example, so you look at, usually you would get an individual solution. So I go onto the, website of the National Heart, Lung, and Blood Institute, and it's like, oh, if you have high blood pressure, here are the things you need to do. So you personally, individual person, you need to do these things: eat better, exercise, take care of yourself, take medication. But then there's no interrogation around what may be happening to you to raise your blood pressure. And we know that this is a place where there's a huge disparity between, black people as a group have higher blood pressure than other groups. But there's no interrogation about what is happening to you on a daily basis in your society that could be raising your blood pressure. And how do you deal with that part of it? And if it is interrogated, it's like, well, you need to meditate, you need to relax. And it's sort of like, well, meditating and relaxing is not going to get rid of the microaggressions that are happening to you, and that is less talked about than the other kinds of solutions. So that's kind of one way to think.
Yep.
Is it your race? Is it racism?
Yeah.
Right, good. So Linda, in the 1619 piece, you talked about, and you both wrote about it and you spoke about it this morning, you wrote about the history of race correction in evaluating lung capacity, that the actual instruments are calibrated in racially sensitive ways. What if we captured that term, race correction, and made it our own as a form of reparations within public health?
Good idea.
Thank you. What would that look like? If we corrected this current system for its racism?
I think we just look more closely at both, the twin problems, how racism in our society and discrimination affects the physical body of human beings, one, and then we'd say, admit that in our current healthcare system, we have a problem of discrimination. And Lynn Friedman is here from Columbia, and I thank you, Lynn, for saying this to me. When we were talking about, her research is on disrespect and abuse in maternal care. So when I was looking, asking about her research, I was thinking, there's some racist doctors here. And you were very clear to me. You said, do not look at individual physicians and healthcare providers as the problem. It is so much bigger than that. It is baked into the current healthcare system, this kind of discrimination. And I never forgot that, because you were very prescriptive to me about what not to do. And I tried not to do that, to think it is a structural problem that we need to admit and attack, and not attack individual people, because that is not the solution.
One of the things that I think comes up a lot in public health is the idea that race is just a proxy for poverty. And it's true that they're related, right? The stories that you told, how people lost access to any notion of recovered assets when after emancipation, meant that the freed population was totally impoverished. And poverty continues to be a key way in which race manifests itself in the United States, but they're not the same.
No.
And the idea, Linda's, talked about ways in which class does not protect black women from risks of childbirth to themselves and their children. So that college-educated black women are more likely to have preterm births and more likely to have adverse outcomes than less educated whites. So these are related but not the same, and they all hinge on the idea of power.
Yeah.
And that's often what's completely absent from the more descriptive analyses that we have, that it leaves out the notion of accountability and power.
I was, again, I try not to read the comments on my stories, but on my maternal and infant mortality story, I did read some of the comments about the woman who was at the center. And so, it was sort of like, well, it's her fault. A lot of it was her fault. She had a dysfunctional lifestyle. She had too many children. And I was like, wait a minute. Did you not read the whole story? Serena Williams, this happened to her. She is wealthy, super wealthy, very, empowered. She's she's a symbol of strength. But this happened to her too. There is something wrong. Race doesn't, money doesn't protect in this. Certainly, poverty makes everything worse, but it's not the only thing.
Yeah. Dr. Bassett, if you had sufficient resources and political will behind you, and we're still the health commissioner in New York City, 3 big ifs, what would be the 2 or 3 things that you would really focus on to begin to eradicate race-based disparities in public health in our city?
A lot of these things I think got started and I hope are still ongoing. For example, working with hospital systems on respectful care. And the health department has now published guidelines on respectful treatment. And so these are things that relate to the notion of interpersonal racism. Structural racism requires action outside of the health sector. I think a critical part of our conversation today is the way in which public health really has no natural boundaries in terms of what can affect our health. And that would take, courageous action. It's heartening to me that many of the Democratic candidates are talking about reparations, for example. But that will, there have been some examples, they were mentioned in that piece, of housing interventions that we think would have an impact on racial disparities in health. The idea of a living wage, for example, not just a minimum wage, but a living wage, is important as a way of addressing racial disparities as well as class disparities in health. So I think that we can focus on the healthcare sector, on the ideas of equal access to care, respectful care. All of these things are very important. But in order to really get at the power that drives the ongoing racial disparities in health, we have to talk about interventions outside of the health sector, ones that involve economic resources.
I think what you did at the health department by requiring your employees
Yes.
to
Yes.
say
Go ahead. Sorry, I should have mentioned that, yes.
to be implicit bias training for all 7,000 of your employees,
Yeah.
and I think that is very smart, and it's a way to say we want to change how people treat each other. I also was
Linda.
Oh, okay. I was
Bring it closer.
closer. Okay. I was also thinking about California. So in California, California now has the lowest maternal mortality rate of all the other states, because in 2006 they had an initiative, and the initiative was around using toolkits, using protocols that all in hospitals, that all physicians and medical providers that are delivering babies, they all have the same protocols to deal with a hemorrhage or to deal with preeclampsia, the reasons that women die. So between 2006 and 2013, the rate of maternal mortality in California dropped 55%. So this is a huge success story using a technology, using hospital-based. But you know what didn't change? The racial disparity is exactly the same as it is in the United States. So what California did in October was to pass a bill that says anybody who is working with a pregnant woman in California must go through the same kind of training that the employees at the Department of Health to look at implicit racism. So that is, so I think one of the things that the myths that we have in this country is that we can doctor our way out of some of these problems or use technology, but without some other kind of connector or some other kind of solution or some other kind of admission that there's another problem going on, we can't solve, you know, health disparities without admitting that there's something else going on.
I want to thank Linda for pointing out that the health department undertook and is still undertaking an internal process, not only an external process. So not only taking a racial equity lens to its programming and policy development, but also undertaking to educate itself on the history. We had a whole series of, in fact, I'll recommend that you come.
have to hire you as a
Of
publicist.
what were called Commissioner Brown bags, so that people could become educated about the history, which many people don't know, and also implicit bias training and built into tasks and standards now. Something that required negotiation with the unions is a requirement that people have racial equity training. So it's now embedded in policy, and one that
That's wonderful.
that I hope will prove enduring no matter who's commissioner.
Right. Let me end with a question to both of you, and then we're going to open it up to all of you as well. If you were advising any or all of the people running for president, whether they are new entrants or longtime runners for president, and there was one thing you could ask them to start talking about, besides health insurance, which is what they're all talking about, but health insurance is a very different question from health. But one thing that you would like them to emphasize that lifted up this intersection of structural racism and health, what would it be?
This is kind of specific, but one, I noticed, you know, when in the conversations around climate change, I think there needs to be a much more robust discussion about who climate change most affects, and that is communities of color in the United States. And so the environmental justice piece needs to be lifted up and I think some of the candidates have talked about it, but not everyone. And that is easy to understand. It's quantified. We know it's, you know, since for 30 years, we've been talking about how communities of color are the ones most have to deal with pollution the most.
Yeah.
But as climate change accelerates, it becomes just worse. So there's so many examples, you know, from Katrina to Puerto Rico and these things that happen, but I don't hear enough of that conversation.
Well, I think that the general stance that we should bring a health equity to every policy would be one that would be wonderful to hear from each of the candidates. In other words, we need to end the silence around a conversation about race and begin to hear the word racism from the mouths of our political leadership. It remains a sort of scary word to use, and that needs to change, and it really has relevance to every policy, from climate change, to health insurance access, to housing, to economic development. And I really would like to see an endorsement of H.R. 40, the bill that is calling for a commission to examine the possibility of reparations.
Yeah.
I think some of the pushback is what the 1619 project was trying to address, to say, because I mean, I think everyone gets this. It's like, well, slavery was in the past, and it's not something that reverberates. And so our goal and our really mission was to say, it's not. In every structure in the United States, it still is here. And so that was part of the goal. So I think talking about that, everyone talking about that is really important, and just believing it.
Yeah. Thank you both. We're going to draw out some more from both of you with questions. I believe there are mics that will be made available to any questions from the floor, so the folks remotely can hear the questions. I have lots more questions, but I want to hear right up front here.
Thank you so much for this fascinating panel and presentation. I have a question regarding the reparations. So you've talked about the context of racism that we live in, and that class is not protective necessarily. I'm curious if you could talk about the impact that reparations could have on health as we move forward.
You're the health experts.
Well, you mean would health improve if we? Well, one of the people who writes about reparations points out the enormous wealth gap that exists by race. Sorry, everybody, about my ability to knock my mic off. The wealth gap is much larger than the income gap. And Sandy Darity at Duke argues that the goal of reparations should be to eliminate the wealth gap. There are different ways that could be done. It doesn't necessarily have to be individual cash payments, but eliminating the wealth gap. Now, if we look at health by wealth or health by income, which those data are more available, we see that health improves when people have more resources. So I would expect that we would see health improvements. And people have calculated the health cost of the racial disparities in terms of lives lost. That's a way of accounting for the cost of racial disparities in health, and that should go away. We would be saving lives. I view reparations as an active set of actions to address current day inequalities that are rooted in historical injustice.
One of the communities that I look at in the book is in Jackson, Mississippi. And I recommend that we accomplish some of this wealth gap remediation through reparations by increasing the estate tax. We're in the midst of the largest intergenerational transfer of wealth we've ever seen on this planet. And much of the wealth that resides in white families that will be passed down to their children and grandchildren was accumulated through real estate ownership over a number of years. A kind of buy land, sit tight, get rich lottery, if you will, that mostly African American people have not been able to get in on. And that's where the source of much wealth in this country can be traced to. So through an estate tax, I recommend that we fund community land trusts. And that's what they're doing at Jackson and in a number of communities across the country. But what's really interesting about what Jackson's doing is they have gotten from the city these big parts of the city that have been basically abandoned, and that we could look at lots of places in this country where that's the case. And the community is building not just housing for the community in which people will live collectively, but also they're doing soil amelioration, they're building urban farms, they're moving themselves towards energy independence, creating public health clinics in their own schools. And all of those will improve not just well-being, but public health as well, or their health of the community. And so housing and collective housing empowers the community through these measures across a range of indicators, whether it's education or health or family or individual wealth, to be sure. And so these kind of measures that get built up through the community, where the community is empowered by them, rather than a top-down, government-run kind of welfare program, if you will, many communities are turning to explicitly as a form of reparations, and it's inspiring. I would encourage you to look at it.
It was really interesting in your book that so many of the people who were seeking to gain land title, well, this was, I guess, especially in the Sea Islands case, that worked collectively to purchase land, like that map that you showed us, was the idea of collective land tenure. So this goal of, every individual having their own personal title was not one that the newly freed turned to. They sought collective action to gain wealth.
Right.
It was inspiring as well.
Right. Well, at the time, that was viewed as a flaw. Right, that freed people were not respecting the kind of nuclear family form, and they were living in more fluid families, and that was seen as a kind of symptom of the evil of slavery, rather than a means of caring for one another and repair. And in the gay community, and another book I wrote talks about this, we too have thought about how to take care of each other in less nuclear, although marriage kind of screwed this up, but in less nuclear units. Not a big fan of marriage. But more as community. And the HIV crisis was something that we learned very, very hard, how to care for one another, whether we were lovers, whether we were friends, that really didn't matter. We were there for each other.
It's worrying that in the wake of the hurricanes in the Caribbean, that places that adopted communal land tenure are seeing it under threat. In Barbuda, for example, the entire island of Barbuda, which was destroyed, it was under communal land tenure. And now there's an effort to redevelop it with resorts and break up the concept of communal land tenure. So it remains a very active idea. But the basic idea here is the idea of redistribution, another word like racism we're not supposed to say. But, it needs to, the only way to acknowledge the extraction of wealth that occurred in this country related to the use of enslaved labor to generate the engine of the economic development that took the United States to its place in the world, is to fix it by changing the distribution of some of that wealth.
Yeah. All right, hands are up. Great.
Oh, I have a question.
Thank you.
Hi, thank you for all of your comments. My question relates to diversity and inclusion, especially around this topic in particular. When I think about race and public health, I think of Langston Hughes' poem, I Sing to America. And in it he talks about, I sit in the kitchen while everybody else sits out front and eats. And oftentimes I have found when we talk about race and public health and, power and structural violence and things like that, oftentimes the people at the table having these conversations do not look like me. And as you've pointed out, most of these topics often affect disproportionately communities of color. So I'm wondering, especially you, Dr. Bassett, because you are a woman of color in a very powerful position, how many people like you have existed in the past in terms of people of color being in high decision-making levels addressing this issue? So when it comes to inclusion at the table, being able to represent the communities that we're talking about, what are your thoughts on that? Because for me personally, I just don't see it. It seems like these conversations are more kind of like in the kitchen still.
Gosh. So I think that you're right, that public health remains a pretty lily-white field. And at the health department, until I became commissioner, the senior leadership team was always predominantly white. When I became commissioner, there were no black or Latinos in the senior leadership team of the health department. So I think you have to intentionally address these types of lack of representation. And the argument that it's such a pity we can't find good people, which is the one that I've heard more times than I would like to say, is just not acceptable. Good. So I'm proud to say that the health department leadership team that I was able to build was the first majority non-white team, including Asians, blacks, Latinos, in the history of the health department. And you know, that I think made us a better health department. I think that one of the things that we always have to argue for is that this is not simply a moral question, and that it speaks also to, Katherine, what you were talking about with respect to power. It's a question of doing our job the right way. It's not right that all of those seminal books about public health left out an important population in our city. I think that I would argue that the work of the health department improved from a technical public health standpoint. Not only became more inclusive, but became a better way of doing public health. But it has to be intentional, because in the absence of intention, we won't see an end of the exclusionary behavior. Everybody picks people who are more like them, with respect to everybody in the room. So it has to be very intentional.
I would just answer that in a slightly different way. I mean, I agree with you, but I'm thinking about how I look at it. So for my research on the maternal and infant mortality piece, I interviewed probably 30 experts, and I started noticing about discrimination in healthcare and in society affecting the bodies of people who are discriminated against. So a lot of these people hadn't been interviewed by the Times before, so I was thinking, they're sort of too loose when I'm talking to them. They're like conversational and talking really long time. Not you, Lynn. And I started realizing, they're doing this not because they're too loose, but nobody talks to them. So they're just trying to get everything out about these topics that are really underdeveloped, in our conversations. And these are the people who have been, and I started thinking about some of the people who had done 30 studies on this. I was like, why are they still doing this? No one's listening to you. But there's just a passion there. The research is there. There's been a lot of work. I think of David Williams at Harvard, who I was sitting next to him at a dinner, and he was talking about his work in discrimination in healthcare and health equity and inequity. And brilliant man, but you don't see him, lifted. I've seen him lifted up more now,
Yes.
but not enough. And so I think we just have to pay attention to the people who are having these conversations, and many of them are Black.
Any specific policy recommendations around the issue of homelessness in New York City through this lens that you've been talking about?
Well, I was thinking about it because I took the train to Penn Station and then uptown. On my train were 3 people with carts filled with important things for them. On the platform were 4 people roaming around the platform. So the presence of street homelessness is definitely escalating in New York City, and I think all the people who I saw were people of color. Most looked like they were of African descent. This is not an area of expertise for me, but I think the obvious answer to homelessness is that people have to have homes, and most of the quote affordable housing is not affordable to people like the people I saw, some of whom also seem to be living in interior worlds, in other words, living with mental illness. So I think that the problem of affordable housing has reached a real crisis. And although more housing is being built, it's not affordable to the people we're seeing on the street. So there has to be an answer to that. It's interesting. I mean, one idea is the estate tax, but we also have had this galloping income inequality in the United States, with the 0.1% being perfect, almost vertical in its acquisition of wealth. And some, the idea of taxes. I mean, the idea that we need to tax the wealthy more is something that's going to be coming up in the presidential campaign. So the notion that there aren't enough resources to look after the impoverished shouldn't be really acceptable.
Right.
There should be a way for government to enable affordable housing for people.
But the lens continues to be, it's your fault.
Yeah.
As it does with many of, when we're talking about health disparity and inequity, it turns into, well, it's your fault. You did something wrong. So I think that thinking also has to shift in a fundamental way.
That's when you say, interrogate this as a racist idea.
Mm-hmm. Well, but I do think these community land trusts and land banking and a bunch of these, what are in the business referred to as third sector housing alternatives, are addressing issues of housing security, not just affordability, but security. Because the affordability is sort of the curlicue on the side of what is really an extreme for-profit model of what it means to live in a city. And what these other models are trying to do is just think about living very differently, both collectively, but also outside of a for-profit speculative model. And I was in Denver talking about the book a month or so ago, and there are groups there that are just doing incredible work in a city that is exploding in size and population. And so they're plotting out new light rail routes to Nebraska or something, that far out of the city, because it's sprawling so far. And these groups are buying up land along where those light rail systems will be, and then they're going to bank it and just sit on it and wait for the communities to develop, but keep that land as both affordable and secure as the city builds out. So it's to take it outside of the for-profit speculative market.
Has that been thought about in terms of public housing in New York City? I mean, many of these developments are on very valuable land.
Yes, they are.
But instead of developing it for, sort of open, market rate housing, could that be?
There are groups doing wonderful thinking about that, but you have to have a mayor and a larger community that is willing to rethink what it means to live in a city. And that it isn't just the survival of the fittest and the richest,
right,
which is what it is now.
Right.
But that the community is richer for including everyone in what it means to live in the city.
Right.
But New York is an extreme case, to be sure.
As is San Francisco.
Yes.
And these are totally unequal places where the homeless problem is the largest, most intense.
Absolutely, right. So, the projects, building a new building with a few affordable apartments in it, which is how we work now, is doomed to fail. And we are living with that failure now, rather than thinking structurally very differently about what it is to live in a place and be a member of that community as opposed to a landowner or a property owner. Another question.
This is our last
We have
question,
time for one more, I believe.
Oh.
We've got one right here. Yes.
My question is about implicit bias training that you brought up earlier. I'm a surgical resident at Columbia, which part of being some of the newer doctors coming up, we are very much, and particularly in surgery, we are fighting our way through the old boys club. And we have implicit bias training at the hospital, but I can tell you it really is just checking a box. We have people come in and talk about implicit bias training. Largely those panels or the trainers are old white men also. How do we get senior doctors and hospital leadership to believe in implicit bias training? How do we make that more effective? basically short of bringing the three of you around with me to the hospital, which I would love to do, but how do we get people to believe in it?
Yeah.
When I was researching one of these stories, I went to Montefiore and asked, because they have a sort of what sounds a bit more intense and robust training. And I said, how did this get here? And they said it was the head of education said, it's the students who fought back. And I said, your students pushed, what happened? They said they pushed back because many of you, in your cohort were politicized by Black Lives Matter movement, or what happened to, shootings of Black men and the activism around that, and came into medical school more political than previous classes and pushed back. And it was interesting to hear this from the person that got pushed into it. So I said, we got to remind students that you have power in your school to say, I need this, we want this. And I think it is your generation that is going to make a difference because of, caring about these issues and wanting to learn more and wanting to do better.
I would, I'm on the Columbia campus also, and our students at the law school have the same objections about the kind of teaching that they're experiencing and learning environment they're in. And they are also taking control of their education, because how the doctors train you is how you will treat your patients, and how they are treating their patients, just as how the lawyers are training our students, will model for them how to treat their clients. And so the students are really quite radical. I was in law school also. We took over my law school and made all sorts of demands. And I encourage the students to do as well, because you are an object lesson for them, for your teachers, about what it is to see people with humanity and dignity and care, rather than in the ways I'm sure you're experiencing.
And I think some of the stories that Linda has told us show how biased behavior drives terrible tragedies and poor health outcomes. So maybe part of this argument has to be that if we care about the outcomes of our care, which all surgeons and all physicians should care about, then we have to acknowledge that things happen due to implicit bias. I also often think that implicit bias training leaves out the fact that we still have explicit bias, and that also needs to be acknowledged. And I want to echo what you've heard, that we are also kind of rendered hopeful by the fact that a younger generation is taking up these issues with such determination and determined to wield some power, which you've done.
Great. Please join me in thanking these amazing panelists and Vital Strategy.
And I'll just step in to say thank you so much for amazing moderation and for everybody's presentation. Another round of applause.
Thank you, Sandy.
Thank you all three of you. I'm sure you all agree this was a great conversation. The beginning of a conversation, perhaps. Maybe we can have other such talks in the future. Thank you all for coming. I wanted to just give a quick thanks to several key staff members who helped to bring this event, in addition to Callie, who I acknowledged earlier, Christina Honeysett, Ali Davis, Karen Schmidt, Brianna Patton-Williams. I'm sure I'm forgetting someone, but you know who you are. And thanks to the Operations Division, Chantal, for all the help to bring this together. So thanks very much, everybody, and we'll see you next year for 6 more of these. So you're on our mailing list forever. Thank you.